This episode is supported by Novo Nordisk.
Welcome to National Kidney Foundation's Kidney Commute podcast pit stop series. Previously known as the Life of the Nephrology Professional, the Kidney Commute pit stop series will continue to explore what we've been doing in the past, whether it's innovation in kidney care, it's focusing on all the topics that you can't wait to hear about. Same series, new name. I will continue to be your host as well. I'm Sam Kent. I'm a transplant nephrologist at St. Vincent's University Hospital at University College of Dublin in Ireland. Today's episode focuses on something which is very topical currently, and I think we need to focus on that quite a bit, especially in clinical practice. I pretty much did it this morning. Individually, I think obesity and chronic kidney disease are epidemics that our medical system continues to grapple with. I think both exist together frequently and are inextricably linked in many ways. You can pretty much see that outcomes in one influences the other quite a bit. But thankfully, we now live in an era where there are excellent treatment options that actually help outcomes in both ailments. For today's episode, I think we should discuss the bidirectional aspect of these two conditions and also essential management strategies. I have an expert panel here today, like always, and I'll pass it over to introduce themselves today. I'll start with Linda Marie.
Hi, everyone. Thank you for joining the podcast. My name is Linda Marie Lavenberg. I'm an internal medicine and pediatric trained doctor and a dual fellowship trained in nephrology and obesity medicine. I currently practice at the University of Pittsburgh as both an obesity doctor and a nephrologist. And my clinical practice manages people with chronic kidney disease, acute care, and I also run a weight management and kidney disease clinic.
Katie.
Okay, hey everyone. My name is Katie Patel. I'm a registered dietitian and a certified diabetes care and education specialist. I work for Southern Illinois University School of Medicine in a family medicine practice. I counsel people for a wide variety of nutrition needs and spend a lot of time in our non-surgical weight management clinic.
Excellent. And finally, Anne.
My name is Ann Dalen. I live in central New Jersey, and I am a transplant recipient coming up on 7 years since my transplant. I also deal with type 2 diabetes as well as heart disease. And since those things feed into each other, you might say, it's important that I discuss these things so other people realize that one thing can affect another. And that's one of the reasons I do this kind of thing.
Excellent. So thank you all for being here. I might just dive straight in. And, I mentioned this part about a bidirectional relationship. So could we discuss the prevalence of obesity in patients with chronic kidney disease, especially from an epidemiologic perspective? I'll start off with Katie.
Yeah, so occurrence of obesity is increasing. According to the World Obesity Atlas in 2023, it's projected that by 2035, 24% of the global population will have obesity. We also reviewed some NHANES data from the period of 2015 to 2018, and 50% of people with CKD stages 3 through 5 have obesity, BMI greater than 30, and of that, 24% have a BMI greater than 35. In addition to that, waist circumference needs to be acknowledged. 72% of people with CKD stages 3 through 5 do have elevated waist circumference as well. So fairly recently, the American Heart Association proposed a term called CKM syndrome, cardiovascular, kidney, and metabolic syndrome. And this reflects the multi-directional relationships among these metabolic risk factors, CKD in the cardiovascular system. So central obesity is the component of metabolic syndrome, as well as insulin resistance, hypertension, and dyslipidemia. Thus, the presence of metabolically unhealthy obesity is a contributor to CKM syndrome. So early CKM syndrome is thought to develop mainly due to excess adiposity.
Yeah, and I think that CKM syndrome is very important to recognize because many people identify the cause of type 2 diabetes and high blood pressure on the kidneys, but fewer people actually recognize the direct effect of obesity on the kidneys. And I think as a practitioner, both primary care and even patients should know that some of the earliest signs of obesity affecting the kidney is albuminuria or protein loss in the kidneys. And what this is actually showing is that early on, before your creatinine starts to go up or your eGFR starts to go down, that this is actually a sign that your kidneys are working harder, something that's called hyperfiltration, and also a sign of a reduction in podocyte density, those filterings, those cells that help create the filter in your kidneys. And, the KDIGO guidelines have recommended that people be screened who are at risk for chronic kidney disease. And I think people who have obesity are in that category. So assessing albuminuria, monitoring their eGFR is important for people with obesity, even though there's nothing that specifically says that people with obesity should be screened. And I think that not only does it allow us to identify the disease and treat it early, but it also helps raise awareness of kidney disease and educate people about kidney disease. And these are some of the national goals to help improve the awareness of chronic kidney disease. And so if we do find this, I think it's important to identify, because there is something that you can do in order to help reduce the effects of obesity, diabetes, hypertension on your kidneys. And that's to start an ACE inhibitor or an ARB, which have the goal of delaying that progression to kidney disease.
If I may interject, one of the issues that I've learned is that people don't know that they have any of these things because they're all silent. And that's why it's so important for people to go to a doctor, have blood tests, do your homework, find out if you're not feeling right. Maybe it is due to one of these things coming on, but more often than not, we feel fine. We go about every day actually practicing the habits that cause these issues. And it's not until we find out that, oh, my creatinine has gone up, I have issues with my kidneys, or the doctor says, you've got high blood pressure, or there's an issue with your eyes. That's one of the things that happened with me when I found out I had high blood pressure. I didn't know any of these things because I ran around, I was busy, I felt great until I didn't.
Yeah, no, that's very important. I think recognition and screening, I think, is such an important aspect of all of this. But as a nephrologist, I'm always intrigued by pathogenesis. I think it's such an important thing to understand why it starts, so that you can focus on the etiology, or why this condition is happening in the first place. So could we talk about the pathogenesis of obesity related CKD and the role of inflammation? I think basic scientists have focused a lot on this in the recent decade. So I think the listeners would be intrigued to learn about how, renal hemodynamics, as I'll sound like another nephrologist, and lipotoxicity. So I'll start out with Linda Marie.
Sure. So obesity is a condition of excess adipose tissue. And, I think a lot of people recognize how diabetes and how hypertension can lead to chronic kidney disease, but I think fewer people are familiar with how this condition of excess adiposity can affect the kidneys. Adipose tissue is hormonally active and is actually a primary source of pro-inflammatory cytokines, especially in metabolic syndrome. And, these key players, inflammatory cytokines like IL-6, IL-1, TNF-alpha, what they do is they attract immune cells which cause this immune and inflammatory response within the kidneys, causing damage and eventually leading to scarring. And on biopsy, what this can be seen as is perihilar focal segmental glomerulosclerosis. And in particular, this elevated TNF-alpha is linked to the production of chemokines, which are produced by the fat cells, adipocytes, and macrophages. And elevated TNF-alpha levels have been linked to even increased fat accumulation. So this pro-inflammatory environment also can be detected by an elevated high sensitivity CRP level. And, Katie, you mentioned previously about the CKM syndrome. And with these high levels of high sensitivity CRP are associated with is the increased development of insulin resistance, inflammation, atherosclerosis, and all these other cardio-kidney metabolic diseases. And what's also interesting is that deficiency in TNF-alpha has been associated with protection from these obesity-induced kidney damage. There's a lot of other things that are produced by the adipose tissues. Leptin is very harmful adipokine, which is higher in those who have obesity. It also promotes inflammation and is actually directly toxic to those podocytes, so causing direct injury to the kidney cells. In contrast, adiponectin is something that is more protective, also secreted by our adipose tissue, that actually has a protective role and has a key role in reducing inflammation, improving insulin sensitivity, decreasing this lipotoxicity. And it also has some anti-atherosclerotic, anti-fibrotic mechanisms. But unfortunately, adiponectin tends to decrease in people who have obesity. But what's also good to know is that some of these new treatments that we have, GLP-1s, SGLT2s, in studies they've shown that these medications can increase the adiponectin levels, so increasing these protective adipokines that we have. Nephrologists are a lot more familiar with the renin and angiotensin system, but so I won't go too much into this, but what the adipose tissue also does is it secretes angiotensin 2, upregulating our renin angiotensin system, which in turn leads to a reduction in the loss of tubular sodium, which leads to afferent arterial vasodilation. So when there's decreased presentation of sodium to the macula densa, that causes this renal arterial vasodilation, causing glomerular hypertension and increased filter load. And this over time is what we see with the glomerular hyperfiltration. And on pathology, what this can look like is a glomerulomegaly, so large glomeruli, low podocyte density, thickening of the basement membrane. A key feature of obesity-related kidney disease, which is distinguishing it from primary FSGS, is the slight disappearance of the foot processes, which is due to that increase in glomerular pressure. So collectively, we've got a lot of inflammation, I think, which causes this stress in the kidneys, a lot of scarring, and over time, this leads to that increase in protein loss and decrease in your kidney function and eGFR.
Yeah, I think the mention of RAS, or the renin-angiotensin aldosterone system, a lot of times you can't get away from it, right? In the end, it's so well linked with nephrologists and also disease processes. But yeah, no, I think those are very good points. I mean, you could literally draw a whole flow chart of how there's so many players in this problem. It's something that we're seeing in clinical practice pretty well, that, quite a bit, that higher BMI is now associated with faster progression to end-stage kidney disease. And I think this is, there's now the study that I might talk about is now almost a decade old, I can't believe, because I used to be quoting this a lot of times when I used to be talking to patients and how important it is to maintain optimal BMI and CKD. So the study that I'm referring to is by Liu et al. In the Journal of American Society of Nephrology in 2014. So I first want to start off with Anne. What are the challenges that are faced by patients with chronic kidney disease and obesity?
Well, one of the challenges that I had found is trying to understand what was going on and why it was happening. That's, you get a diagnosis and your ears shut down. Your brain goes, no, not me. And so you need to come to a place and work with whether it's your doctor or your nutritionist, somebody that can help you understand why this is happening. I found out that diabetes can take years to show up for the patient to realize, and I mean a lot of years to realize that they now have type 2 diabetes. That's been affecting their kidneys the entire time, and their heart and the rest of their body, and we don't know this. So I think a lot of it has to do with education and also being given the tools to understand how you can learn to manage things. Because doctors sometimes, and I'm not saying all, but I've heard this so many times in my diabetes sisters meetings, they're given a glucometer and they're told, use it once a day, use it, this, do that. And when it comes to eating, it just says, try to eat a little bit better. Okay, what does that mean? So those are obstacles that the patient has to, I guess, take the initiative and go, I don't understand, and ask a question. And quite often patients are a little intimidated because they don't know what questions to ask. And so it's a process that takes a long time, and you want to work with your doctor, if I can use the word, as a partner, so that I know people that have been given different kinds of news regarding their health. They don't go back for a second appointment because they're afraid, and if they don't improve things, they go, oh no, I'm going to be in trouble. This is not good. Instead of being told, no matter what you're doing, come back. We need to work through this together. So there are different things that need to be done, but I think that's a big part of what people can face.
So I might ask Linda Marie to talk about the study I just mentioned about obesity and progression of chronic kidney disease.
Sure. And thank you for those comments. I think that those are really important points of how we can improve our communication with patients. And I love the idea that you said, like, come back to come and talk to us about it, because I agree with you. I think once people hear that diagnosis, it gets very scary. And I think I'm going to be talking about a little bit of scary things right now with this article, but I think hopefully we'll come back to it and wrap it around to make it a little more lighthearted at the end. So what this study showed is that there were worse outcomes in all people if they had a BMI that was less than 25. And to kind of put that into reference, that's like when people are actually in their normal weight range, they had worse outcomes. And that was independent of the severity of their chronic kidney disease. But they found that BMIs that were greater than or equal to 35 was associated with worse outcomes in people in earlier stages of chronic kidney disease. And this association was attenuated in those patients who had more advanced chronic kidney disease or EGFR that was less than 30. So this is around stage 4 kidney disease. What I think this is highlighting is that the pathophysiology of obesity-related kidney disease can explain the findings of worsening kidney function with higher body mass indexes. But these studies also highlight the obesity paradox, and that's when we see lower mortality risk is observed in people with obesity. Which, when you're hearing that, that might make you as a clinician feel uncertain as to whether or not you should recommend weight loss in people with advanced chronic kidney disease. And since that study, there's been a lot of other studies that have been trying to tease out this obesity paradox, because it's not something unique to chronic kidney disease. I think, in cancer research too, they show that higher body mass indexes have a more protective advantage too. But there's a newer study by Mira Harhe, which I thought was really great. And what she did was she tried to phenotype or characterize these populations that were at higher risk of mortality beyond BMI alone. So what she found actually was that patients with obesity and chronic kidney disease, and she was using the CRIC cohort, she found that those who are experiencing an increase in their body mass index relative to their increase in free fat mass. So what this means is an increase in BMI, but they were having less muscle mass. She found that that group of people had a higher risk of death compared to those with a proportional gain in both body mass index and fat-free mass. Thus, her study also showed that high-risk weight loss patterns were in those who had quick weight loss. Their blood pressures were increasing, their systolic blood pressures were increasing, and they're seeing a decrease in their serum albumin. So what I take away from these studies is that someone who has malnutrition, they're losing weight, and it's not intentional, those are signs of higher mortality risk. And the focus should be on improving their nutrition and reducing their muscle catabolism. I would not recommend weight loss if I saw a person with this, despite them having a higher body mass index. But what I do see is that, body composition testing is actually really important and can be very helpful. Unfortunately, it's not very accessible in the clinic. I hope that can change, because I think that there's a lot that we can gain from body mass compositions. But what is important is that, we should still encourage for everybody, regardless of their weight. I think it's just helpful to encourage and be more specific. And what you were saying, don't just tell me to lose weight, don't just tell me to exercise or eat healthy. We should encourage physical activity, healthful diets, but give some good, hard suggestions. And I'll leave it to Katie to give us a little bit more details about later on. But in those people who, they don't look like they're frail, they're not unintentionally losing weight, we should try to encourage these healthy practices, because these approaches can help decrease the inflammatory response, decrease the lipotoxic effects. If we are able to reduce some adipose mass, we can improve their quality of life, and we can also improve access to transplant, because obesity can be a barrier for some people.
So I do want to touch on some additional challenges that people living with obesity might face, just so we're able to provide that non-judgmental care. People living with obesity and chronic kidney disease are faced with quite a few challenges. Obesity actually disproportionately affects people that are at a socioeconomic disadvantage. People live in what we call an obesogenic environment that can consist of low income and food insecurity. When people have limited resources, they also experience a lack of access to healthy, affordable foods, and even live in a food desert where there isn't a grocery store or fresh produce available within a mile of where they live. So in this environment, people might have fewer opportunities for physical activity. We might suggest we'll take a walk in your neighborhood, but if they don't feel safe in their neighborhood, they're not going to be successful with that. And we need to understand that everyone has different tools in their toolkit when it comes to lifestyle changes. People living with obesity can also face emotional challenges like weight stigma, which is, so this is the experience of perceived rejection or their experience of devaluation based on their body weight. This does happen in healthcare, and it's typically subconscious. Healthcare providers don't realize that the language we use, the way we speak to our patients, can lead them to perceive weight stigma. And this weight stigma is associated with low self-esteem, depression, mental health, and developing maladaptive coping mechanisms. So this can happen if a provider makes maybe certain assumptions about the patient, like assuming they're overeating, non-adherent, or even just assuming that they're lazy or not willing to engage in lifestyle changes. And this bias can lead to a reduced quality of care and sometimes avoidance of medical care, like Anne had mentioned earlier. I also think, Anne, you mentioned the lack of education you might receive in a doctor's office. They're so short on time in that clinic visit, but referring to a registered dietitian or a diabetes care and education specialist is so important to give people the tools that they need to be successful.
I agree with you so much. And there's one other element that is super important to me and to many others, and it's support. Find others who have the same issues. That's why I'm a member of Diabetes Sisters. We have every type of diabetes, and it's not just 1 and 2. There are other forms of diabetes, and we all experience the same thing. When it comes to my kidney issues, same thing, heart issues. Without support from others, it makes it very difficult because generally the people within your support groups, they understand you. They understand what you're going through. And weight stigma, people have no issues commenting, and you see it online, social media. Oh my gosh, look, she's gained weight, or what happened? It's just ongoing. So when you have that in your face all the time, it makes you devalue yourself. It makes you doubt yourself. It makes you go, it's not worth it. I mean, the things that we do to ourselves when these things are coming at us and without others to support us, it can be very difficult to move on and make positive changes.
But this conversation shows you, right, that multidisciplinary care is so important, with the patient being the most important team member in that multidisciplinary care. So I think addressing these things from so many angles is so important rather than just the one angle. I think we can have this myopic view of just having the physician's perspective, but I see it's important to have the dietitian's perspective, patient perspective, psychologist perspective if they're involved. So yeah, I think all of you make such great points on that aspect. So I think in this episode, which is part 1 of 2 of the series, we discussed a few aspects. I think we talked about the epidemiologic data around obesity and CKD. We also talked about how higher BMI is associated with faster progression to ESKD and various aspects associated with that. For part 2, we will be back with management, most importantly, the holistic aspect of lifestyle interventions, and then medications and bariatric surgery. So thank you, our guests, for the first part, and most importantly, the listeners. Thank you for tuning into this Rite of Kidney Commute Pit Stop podcast series. If you have any comments or suggestions for future episodes, please email the team at nkfpodcast@kidney.org. Remember, the world of nephrology is always evolving, just like the kidneys, constantly filtering through the latest innovations. Stay curious, stay informed, and most importantly, stay connected. Thank you.